Well, I'm hopeful that this presentation encapsulates what I see as a recurring theme in a patient journey, a patient story, resonating and recycling events. And I really, I know maybe I see myself only on the screen, but I'm hoping we can bring the entire panel on the screen and to make allowances for a dialogue and a discussion. We have endocrinology, we have myself as a hepatologist, we have primary care, and we can talk about this specific patient's journey. Now, trying to advance my slides. Here we go. So this is Jorge. Jorge is a 55-year-old Hispanic man. He has a known past medical history of hypertension, type 2 diabetes, weight gain, and now obesity with a BMI of 34 and hyperlipidemia. And as a primary care physician, you've been following him in your primary care clinic for annual examinations, and you're seeing him for his routine clinical care. 3 months ago, almost had to increase his glipizide, went up from 5 to 10 milligrams twice daily because he has chronically been struggling with his glycemic control. His hemoglobin A1C is now 9.5. He seemed happy. He seemed well. He just returned from a vacation in Florida. He took his 3 kids. He's a busy executive. And you're in kind of angst. His hemoglobin A1C and his metabolic syndrome is not well controlled. And you could tell that after years of hearing how he needs to get this under control, he's clearly frustrated. He's frustrated that he's gained 22 pounds since his diagnosis of diabetes a year ago. He's made every attempt to eat healthy and to be physically active. And he looks at you and he says, "Doc, I've done what you wanted me to do." His medications are metformin, 1,000 milligrams twice a day, glipizide, 10 milligrams twice a day, rosuvastatin, and lisinopril. Overall, he feels well. He did get a tattoo while he was in Florida. And you make earnest attempts to ensure he didn't get hepatitis C while he was there. You check his hemoglobin A1C. And you say, well, record your blood sugars, diet and exercise again. And hold on, struggling with my, and you refer him to a dietitian, but the patient looks at you and says, "Doc, I'm just too busy for that." Now, here already is the epitome of what we see in clinic, and I'm just kind of opening this up to where do you start? Where do you go? If the patient's frustrated, clearly as providers, we too are sometimes frustrated. And how do we approach this? Dr. Cusi and Dr. Juan.
Are you throwing the ball on us? Okay, number one, I see that Florida is a very dangerous place if you have diabetes. It's also fun. You get a tattoo and everything. So I'm in Florida, so I won't take it personally here. But again, this is a typical situation in which you're gonna need to do something different, and sometimes you wonder what could motivate the patient. And I think one of the aspects would be to know if the patient is at risk of liver disease. So sometimes identifying that they have steatosis, even more if they have advanced fibrosis by non-invasive tests, can be the tipping factor for them to get into to change things. So I was thinking 22 pounds in a year, that's an extra 77,000 calories. I mean, so there's definitely some anxiety, some factors that are driving him to overeat. Could be stress, could be anxiety, could be lack of education, people drink in some coffee shops that I won't name, any of these frappuccinos or whatever have 700 calories. So we have to start here with a team approach that we talked about before. I don't want to reiterate, but we need to get this person to understand that the meaning of all of this with 3 kids, find which is the motivating factor that you could leverage. Maybe his kids, maybe feeling better. I don't know. But clearly, he needs to do lifestyle changes. And again, he would be apparently an ideal candidate for a GLP-1, which can reverse, compulsive eating. The question, there's a lot of questions here, which I'm probably going to need to address: alcohol, other causes of weight gain, a lot of other things. But I'll just start there. That this is going to need a team approach of a nutritionist, behavioral modification, rule out other causes, rule out depression, rule out other medication that he may be taking. So complex. This is not something that you can do so easily in a 20-minute visit, right?
Right.
Yeah. I'll just make a few points too. I've been blessed. I have the best of both worlds. I work both in primary care and hepatology. And so, from a primary perspective, I usually tell my clients, the goal of having a primary care provider is to help prevent disease, right? We do not want to wait for complications to arise. And you can see, that's usually how I kind of, introduce these issues with my patients. What diabetes and heart and blood pressure and cholesterol is really telling us is there a risk of heart disease, and really not how long you live, but your quality of life that you live. In regards to Dr. Cusi's talking about children and getting older and being able to enjoy life and travel and things like that. If I think of this from a hepatology standpoint, I could see a few concerns here that would alert me. The fact that his A1C is not controlled, with a target of less than 7 is what our aim is here. He's got, clear kind of features of metabolic syndrome, probably at higher risk of liver fibrosis, also of Hispanic descent here. There's genetic factors going on. So I would start worrying about whether he has more advanced fibrosis. The fact that I see that he's been diagnosed with diabetes just 1 year ago, whether, was he really being monitored regularly? Has he had diabetes maybe longer that went undiagnosed? Obviously the longer you have untreated diabetes, the higher the risk of other complications.
I have the vantage points of seeing patients by the time they get to a specialty clinic. And by the time they get to a specialty clinic, they know it's serious. Here I am seeing a liver doctor. I must have cirrhosis. But I don't see sometimes the challenges that I've done everything you've wanted me to do. I'm trying to diet and exercise. I don't have time for that dietitian. I'm a busy executive. I've got 3 kids. I don't have time to make it to the gym. How do you address this? Because by the time they get to me, they're willing to do anything. By the time before they get to me, it's just kind of laissez-faire. I'm going through life. How do you get them on the bandwagon and peel back these layers of frustration?
Yeah, I mean, I guess, it's the same kind of idea is really about prevention, not waiting for you to have, a major cardiovascular event or a stroke or, having to go on dialysis, in that sense, before we make a change. Again, this usually needs a multidisciplinary approach with whether a dietitian and, a good primary care team, even counselors or therapists can get involved here, and an endocrinologist to kind of really help optimize his diabetes control.
So we kind of, forgo, okay, he's too busy for the dietitian. We're going to have him follow his blood sugars, recording his diet and physical activity. Just a little glimpse of his family history. His mother died at the age of 62. She also was an insulin-dependent diabetic, hypertensive, dyslipidemic. His father had hypertension, hyperlipidemia, and a myocardial infarction several years ago. He reports he was noted as a child that his parents both had difficulties losing weight and easily gained weight, but really there is no family history of liver disease, cirrhosis, or liver cancer or need for transplant. He was born in Mexico City. He has lived there until he met his wife. He was an exchange student here in the U.S., from the U.S. At Mexico City. He married during college, moved to the U.S., has attended business school, works as a stockbroker. He drinks alcohol socially at business meetings, maybe once or twice a week, but has never smoked, doesn't use cannabis, no illicit drugs. And he's able to complete his activities of daily living without any problems. His exercise is light. He admits he has mostly a desk job on the computer, walking from car to work and from the garage to work, really only about a half-mile round trip at any given time. His review of systems is really unremarkable except for chronic fatigue. Almost overwhelming. It's reduced his sex drive. He's too tired for that even sometimes. And he's positive for polyphagia, denies polydipsia or any cold or heat intolerance. Examination, borderline hypertension. His liver edge is palpable, and he's got an increased waist circumference. But when you see him back at 3 months, he's still, if he increased his glipizide, his A1C is a little bit better, but still at 8.7. Testosterone levels normal, and his AST is 65, and ALT is 65, and his AST is 55. All measures of liver synthetic function are normal. Fasting glucose is 128, EGFR is 80, thyroid function's normal, and on his rosuvastatin, his lipids are normal. So what's going through everybody's mind at this point?
Yeah.
Well, go ahead, Jorge.
Go ahead, Dr. Cusi. Go ahead. Yeah.
No. Number one, definitely his decreased sex drive is not from a low testosterone. He's almost in a testosterone storm. So we got to be careful, but it's normal. So, but again, fatigue is a multifactorial condition, right? So I learned, so his sugars are high, that hyperglycemia by itself can cause polyuria and chronic fatigue. I have learned very well from Manal and my liver colleagues. A platelets of 155,000 nowadays raises my eyebrows. I mean, this is not good. I mean, well beyond, and that AST of 55 is also another red flag. So I'm sure Manal is thinking that there's something going on with the liver at this point. His lipid panel has a low LDL, but that low HDL of 32 is in itself a risk factor for cardiovascular disease. So fatigue could be that he has maybe diastolic dysfunction or undetected heart failure. That could also be accounting maybe for some of his weight gain if he has water retention. So definitely I would have him be evaluated with by some means, an echocardiogram, whatever. He definitely is gonna need a GLP-1 and or insulin for that, and for his A1C. And again, I would like to do an additional test for his liver. And maybe he has depression, so maybe he would need an evaluation for depression too.
Yeah, I totally agree. He definitely would benefit from a GLP-1. I would actually even advocate for an SGLT2 inhibitor as well, to reduce his risk of kidney disease and cardiovascular disease. In regards to his fatigue, definitely risk for sleep apnea. I just would want to probably send him for a sleep study. I usually consider sleep study and a stress test or an echocardiogram for all my clients who I'm seeing with a high BMI, which is a huge risk for general fatigue. I often say that the most common symptom of liver disease is no symptoms, and people don't really get bad symptoms of liver disease until it's too late. And so notoriously, people don't look like they have liver disease. So it's you do have to be a detective and kind of be suspicious in the sense. I do agree that a great caveat with liver disease is when that AST is approaching that ALT, where they're almost close to 1-to-1. Is a nice a bit of a red flag. As long we didn't talk much about platelets, but obviously it's in the Fib4. But that was one of the first kind of clinical highlights I learned with liver disease. When you're seeing platelets dropping, or maybe not even low as yet, but a steady decline in people's platelets is usually a bit of a warning sign to look for advanced liver disease, portal hypertension. So you can see that here in his blood tests.
Can I ask, just taking away, we're biased. We're in a MASLD talk in a MASH thing, right? And so it's aimed somewhat at Dr. Cusi, but in primary care overall. How do you motivate these patients, right? Like you need something, like as we heard from the patient perspective, something to motivate and say, hey, listen, I can do something that will actually change potentially my natural history beyond, we'll pile on drugs, yes, and not so challenging sometimes, but do you use the family history? I mean, he's seen his dad, I think it was dad or somebody, first degree MIs. And so what do you do? What do you get them, from a non-hepatology perspective? How do you?
Well, this is just personal, just being old with patients. So telling them that they're going to die of complications rarely motivates people. But but he has, some red flags. Mom died at 62. We don't know what. His dad had events. I think what I've found first, because philosophically, we are in a society where we value more what we do and can earn and prestige over our own health. So I think that's something, but that's a deep conversation that usually occasionally happens with people. But I found that thinking about the kids and telling them, kids are really motivating. I mean, sometimes the spouse, not very often, but the kids touch a vein. So if I cannot motivate them because of love for themselves, I think kids do the trick many times. I would tell this guy, you're not going to see your kids getting married or even graduating from college if you don't change. You're really, I would like to say it, don't use it on the patient, but you're really a train wreck. You're going to hit the wall hard very soon from diabetes, heart disease, liver disease. His EGFR is still normal, but it would decline. We don't know what his blood pressure. His blood pressure is there. Well, he has probably some degree of hypertension, throughout the day. Yeah. This person needs to really do a radical check. Right. How I use the kids. That's very powerful. Or if the spouse is there, typically, particularly if it's a male, the wife give him a hard time.
It's fear of the
many times for shopping and cooking. So that's another ally I have.
So there's no general right answer to that. It really is getting to know the patient and knowing what's important to them. That could be kids, that could be traveling, that could be their spiritual their religion, that could be so many different things. So it's really kind of trying to find out what is important in this person's life, what's worth for him living, and what would he die for, in a sense, whether that's his kids and so it's different for every patient, for sure.
Yeah. So great discussion. I'm loving this. So by the time they get to me, this theme resonates. Doc, I family history, strong for insulin resistance, strong for maternal diabetes, uncertain whether parents did or didn't have chronic liver disease in the background because they were never evaluated. But this theme of fatigue in the context of chronic liver disease is very real, and is in fact a barrier to achieving success with diet and fitness and exercise. So it is kind of a root cause of frustration. And so when I see this, I'm too tired, I'm chronically fatigued. One of the concerns that resonates in my mind as a hepatologist is am I missing subclinical hypothyroidism? The answer here is no. am I missing hypogonadism, because that becomes very real in the context of progressive hepatic fibrosis? The answer is no. Is there underlying cirrhosis, with especially with this platelet count of 155, because then that introduces an element of potential sarcopenia and muscle wasting, and I really evaluate on examination for other signs of temporal muscle wasting, small muscle wasting, because then that might lead me more to some resistance exercise. And I drill down, as Dr. Cusi and Juan have already pointed out to, that there aren't any confounders trying to correct the hyperglycemia, and GLP-1 use, even in my mind as a hepatologist, resonates, ensuring there's no obstructive sleep apnea. And interestingly, in the patients that I see in a NAFLD clinic, about 90% will have mild to moderate obstructive sleep apnea that's gone undiagnosed. I don't know why the strong association, if it's part of the weight gain, and even in lean NAFLD, if they're of Asian and Hispanic descent, because of the anatomy of their jaw, they're at increased risk for obstructive sleep apnea, and I readily get that corrected. And sometimes they'll come back and say, I feel much better, and revisit, picking up on physical activity. Would anyone in here, now that his liver enzymes are normal, he's been on rosuvastatin, it's nothing blaring, feel the inkling to do anything about the statin with elevated liver enzymes? Because he now says he's fatigued, doesn't have the gumption for exercise, his liver enzymes are elevated, and there may or may not be any pressing biochemical reasons for continuation of a statin.
Well, real quick, I think we would keep such a person in general on a statin long term, just because of diabetes, as we know that even if you have LDL below 100, you would use a statin. Now, that low LDL with just 10 milligrams of rosuvastatin, for me, it's a red flag for also losing hepatocytes. So that I think this person, because putting it all together, may be at risk of advanced liver disease. But you could eventually discontinue the rosuvastatin for a week or two and see if that's fatigue should go away quickly if it's the statin causing subclinical myositis, in my experience. So I do that experiment sometimes. But as you know, from the cholesterol trialist meta-analysis in 160,000 people, the rate of elevated liver enzymes is 2%, and in placebo, it's 2%. Yeah. So chances of it are very low. I do that only if the person is blaming the statin, but I would be inclined to just keep it at this low dose.
Well, Dr. Cusi, you are definitely thinking like a hepatologist, because when the low LDL in somebody with metabolic syndrome and diabetes starts to decline, even on a statin, certainly as low as 80, if not lower, I really start to become concerned about the severity of underlying liver disease. But you asked for his FIB-4 score, Dr. Cusi. You said you'd calculated it's 1.9. It's kind of in this indeterminate range. Now what? What are you going to do, and where do you go from here, either from primary care or from an endocrinologist standpoint?
Yeah, so definitely this is where your clinical kind of suspicion and skills kind of come into place, right? So you have a FIB-4 score in an indeterminate range. You also have some other kind of, a little bit of red flags with the uncontrolled diabetes, the low platelets, the ALT and AST getting close to each other. You have the LDL dropping. And so you're very suspicious of more advanced liver disease. If you have access to more testing, a FibroScan would be great. I would, there you go. And then I would probably order a baseline ultrasound on this client as well.
Okay. So you decide that you want additional testing for the FIB-4 score. We've touched on what now with the statins, and it's going to be a little while. You don't have access to an immediate FibroScan. Do those elevation of liver enzymes prompt you from a primary care standpoint to follow him differently? Are you going to see him at a year? Are you going to see him every 3 months? Are you going to see him every 6 months? How would you follow him? And I'd be interested, especially in Canada, what is mostly in your armamentarium of tools to manage this FIB-4 score?
It's even sometimes the FIB-4 score is a bit challenging. I mean, the AST here is not funded in the sense that you would have to pay for the AST unless it's ordered by a liver specialist. So it's a discussion, and it's something that we have to get around. But and same with the FibroScan. So the FibroScan is usually something that we refer to specialty clinics for, or a hepatology clinic if they have access to. Clients are usually paying out of pocket for this test, and so it's not always available. So definitely your clinical suspicion is a huge role here. From a primary perspective role, based upon what I've seen, definitely a baseline ultrasound would be warranted. If you're savvy, I mean, a great thing to ask on an ultrasound requisition is, are there, first of all, is there any signs of fatty liver, and then even signs of portal hypertension, right? Are you seeing a large spleen? Are you seeing any nodularity of the liver? Some clinics will be good enough to make some of those points, and that would also, raise the suspicion for cirrhosis as well.
So I was on the practice guidelines for writing the new NAFLD and NASH guidances, and we had a huge deliberation about does an ultrasound change or not change management. And with the advent of having a CAP score on a FibroScan, I guess we can readily see if somebody has increased liver stiffness, liver fat content. The platelet count is almost as good as a surrogate for hypersplenism is the assessment of an elevated an enlarged spleen. But the reason I put this up here, elevated liver enzymes, follow or evaluate now. From my vantage point as a hepatologist, my patients will come in and say, well, doc, I've been followed for 10 years. My doctor checks my liver enzymes every year. Nobody's made anything about it. So the question is, in the realm of primary care, when do you pull a trigger? And at what threshold of liver enzymes is a reason to be concerned? A true normal liver enzyme for a woman is under 20, and a true normal liver enzyme, AST or ALT, is under 30. And I understand the bell-shaped distribution of liver enzymes, but what is the go, no-go of do I follow, or do I evaluate, or do I refer? Is it based on liver enzymes or other totalities of data? Because it's not uncommon for patients to be followed for many years.
Yeah. So, I mean, sometimes the discussion I have is not what a result shows at one time, but really what a pattern, the pattern of the liver enzymes. So is this a pattern where the liver tests are continuously elevated? Are they rising over the years? But definitely something that we would follow if it's staying consistently elevated, along with other metabolic changes like the diabetes and the cholesterol, and so that would be my kind of red flag to continue to follow if the liver tests remain high and elevated, along with other risk factors for progressive NASH, MASLD.
I think Canada, it's become very challenging in primary care comparatively, perhaps to the US. There's missing gaps and missing areas in primary care because you don't have that ongoing follow-up. And, leaving messages simple is probably best because they may only interact with primary care once or twice. And, elevated liver enzymes is abnormal. I take your point, Manal, this 20 and 30, I tell my patients of autoimmune hepatitis, for example, you're less than 20, less than 30, we're great. But for primary care, as soon as it's abnormal, they should look at something else because you're so right. There'll be a decade goes by and they've had abnormal liver enzymes and nothing's been done per se, right? And
I have to say, Alnoor, I agree. I worked at the VA 25 years. They have an electronic medical record that goes 20 years. I cannot tell you the many times in my clinic in diabetes that the fellow would present and, oh, liver enzymes are elevated. I asked him, what do you make? Well, yeah, transaminitis, they say, and move on. And you've seen that they've had elevated liver enzymes forever. They've had colonoscopies. They've seen gastroenterologists. No offense, Manal. And nobody has done anything. I mean, and I think now there's a greater awareness, but there's so many missed opportunities. Almost every person with cirrhosis, at least in a closed system like the VA, could have been prevented. I mean, with more awareness among endocrinologists and primary care. So I'm not pointing fingers. I think our awareness has been pretty low in the past.
So I'm going to leave you guys with one pearl that I, as a hepatologist, I hope that we can carry away. Think of the metabolic syndrome in the patients that you're caring for, and stop worrying about the liver enzymes, because the liver enzymes, in fact, drop and may even normalize in the context of cirrhosis. So improving liver enzymes does not recluse us of the potential that somebody is getting better. In fact, they may be getting worse. And if the liver enzymes are improving in the context of a declining platelet count or in the context of persistent diabetes, what I would hope that you can follow is once a year, instead of looking at the liver enzymes, check a FIB-4 score. And the FIB-4 score is rising irrespective of what's happening with liver enzymes. That's a reason to be concerned if one can do an AST readily, or couple that every few years with a secondary biomarker like an ELF score, transient elastography, to further empower the informative guidance that you may get from a FIB-4 score assessment. But it's not too often by the time that I see a patient with a platelet count of 125 and normal liver enzymes, they come to me and say, well, my liver enzymes have improved. And then I have to say, well, yeah, because you have cirrhosis, and explain that. Well, I've gotten my liver enzymes better. So the liver enzymes, the pattern thereof actually has no sensitivity or specificity to the severity of underlying liver disease. So great discussion, though. So I'm intrigued. Dr. Cusi, you mentioned you indeterminate FIB-4 score. What would you do next in your scope?
I mean, as you know, we've screened like 1,500 people in a research study just with FibroScan, and I would have to say that very few have FIB-4s above 2.67, which is the extreme in primary care in non-hepatology settings. So I would say anything above 1.3 is suspect, and typically if it's above 1.67, which is a cutoff we found in a study in people with diabetes, it's almost, I would say, 90% chance they have F2, F3. So I definitely want to do a second test. I think the elastography, transient elastography, is the more practical and probably more helpful.
So let's get the screen back up.
Let's do it. So we have little time.
Let's do it. So we have a FibroScan, and if we can get the screen up, my slides, that would be great. And his FibroScan showed a liver stiffness of 6.2, slightly elevated CAP score, not much. And is this somebody that we can follow in primary care? And if so, how would you potentially follow?
Well, if you ask me, this is the test, I wouldn't believe it, because with that profile in diabetes, he has all the risk factors. It doesn't matter if it's MASLD or NAFLD or whatever you want to call it. Those platelets, I'm very worried. I would send them to somebody like you to do an MRE or beyond.
So this patient did get followed. The FibroScan stiffness score was under 8. He got followed in primary care, and that's okay for a period of 2 years. He shows up for his annual physicals in the interim. And interestingly, his primary care doctor did put him on a GLP-1. He's lost 10 pounds. He feels better. He's less fatigued. His transaminases have improved, but now his platelet count's 135. Hemoglobin A1C is 7. And 2 years later, you recalculate his FIB-4 score, and in fact, it's gone up. It's gone from 1.7 to now it's 2.9. And his CAP score, his liver stiffness has increased from the 6.2 to 14. So there is a trend here. And the questions then, does the patient need a referral at this junction? Should you consider a liver biopsy? And are there other considerations in your care from the vantage point of a specialist or primary care physician?
So before Juan, you mentioned, I need to say something. That FibroScan was wrong. Just from an educational
I'm surprised that his FibroScan's gone up and his weight's gone down.
No. It's just for the primary care. You don't progress from, the bad number of 8 that is from 6 to 14 in a year or two. So unfortunately, I had a bad test. Now that 250 could have said, well, this poor man doesn't have any more hepatocytes, but that LSM was definitely wrong. So again, for the primary care doctor, for endocrinologist, I learned with that metabolic profile, years of diabetes, uncontrolled, low platelets, high AST, you don't need a FibroScan. Probably just send to your hepatologist. He'll do a good job in sorting this out.
So irrespective of whether that FibroScan was right or wrong at the first juncture, there's a trend. So you can couple the trend. And yes, despite his improvement in glycemia, despite his improvement in weight, remember, there's no GLP-1 receptors in the liver. So I suspect this FibroScan is telling of where he was and where he still is, which is high stiffness. But to appreciate the nuances of multiple complex pathophysiologic processes that can continue to render an increased risk for fibrosis progression despite some weight loss. And so I'm not sure I would refer him personally to bariatric surgery but certainly I think I would refer him to a specialist to consider maybe emerging therapies for MASH or for cirrhosis, or to ascertain the truth of these non-invasive markers. So he does come to somebody like me, and given his increased risk, given the platelet count, given his family history, given 3 or more metabolic risk factors, the current concern that he's diabetic, he gets a biopsy, and here it shows he's got steatohepatitis and what we call bridging fibrosis. One could argue whether it's even cirrhosis, but pathologist calls him stage 3. So at this juncture, approach to care, both with lifestyle or pharmacotherapies, I'd be interested in how he should be followed or where he should be followed, and what should or shouldn't be done at this juncture.
Juan, go for it.
Yeah, I think part of this depends on the comfort level of the primary care managing cirrhosis. But one thing the primary care doctor can definitely continue to do is know that this, he's at increased risk of liver cancer and HCC, and that should be screened. And so that could be done at a primary care level in regards to getting an ultrasound every 6 months. I think that's important. People always want a treatment for their fatty liver. And I don't know if that's because of the stigma, or they see it on an ultrasound and they want to you can't really see diabetes or cholesterol, but they want a treatment for their fatty liver. And, I try to kind of think of it, I want them to think of it more of their heart, in regards to, are you doing everything you can to reduce your risk of heart disease? And that's controlling your diabetes, your cholesterol. Are you staying active? Are you eating the right things? Because the same thing that's good for your heart will also keep your liver healthy as well. In regards to, he does need forever monitoring and ongoing HCC screening. Whether the hepatologist thinks it's worthwhile screening for varices or an endoscopy, his platelets are low, which could be a sign of portal hypertension. That can also be done as a screening test. And in regards to pharmacotherapy, again, just optimizing his diabetes control. I do think statin therapy is warranted here. I always talk about the risk and benefit of medications. I think the statins have a higher benefit than a risk to this client because of his risk of cardiovascular disease.
Yeah. You're on mute, Dr. Cusi.
Mhm.
No, I agree with Juan and all of that. Vaccinate for hepatitis, viral hepatitis. And also, this is a complex patient. This person will have to see an endocrinologist because it has long-standing diabetes. The GLP-1 might not get his A1C, and now it might be at 7, but might creep up. I would also offer this person pioglitazone, at least 15 or 30 milligrams, because on top of a GLP-1, they're going to continue anyway to lose weight. That's a study called Sustain 2, combining adding to people with prior GLP-1 like sema, you keep losing weight anyway, and that might prevent progression. So this person really needs a very integrated, multidisciplinary approach, nutritionist, behavioral modification, help from all angles. I mean, and what do you think, Manal?
Yeah, I agree. So once they see the element of chronic injury, the multidisciplinary approach is essential. And usually by this time, patients are more motivated, sadly. But the truth of pre-cirrhosis, or the word cirrhosis, motivates people. And I get the dietitian involved, I get behavioral medicine involved. I don't find a role as of yet for genetics or genetic that the knowledge of a PNPLA3 gene influences my approach to therapy. And I am usually referring them to endocrinologists with one plea, is help me manage their diabetes in a non-obesogenic manner. So I, as a hepatologist, hate insulin. Okay. I hate it. I understand it's cheap. I understand it's affordable. And if I could get everybody on a weight loss treatment regimen for their diabetes, that's great. SGLT2s, GLP-1s, maybe low dose pio, I don't know. That may or may not be a limitation in Canada. And I start surveillance, as Dr. Juan has already said, an ultrasound every 6 months to a year. And when platelet counts drop below 150,000 and certainly below 100, baseline screening assessment for esophageal varices, which can be done every 2 to 3 years thereafter, and vaccination for hepatitis A and B. And then I start to follow them for measures of liver synthetic function every 6 months with a MELD score.
I have to say that unfortunately, intensive insulin therapy always causes weight gain. And in some places like this, like in patients like this, they often get on a U500 that causes hypoglycemia and a lot of weight gain. I was just with a patient this week, Tuesday actually, he was long-term on sema, and we added, and this person was on U500, 220 units. It's like 1,000 units of insulin. And we gave him 15 milligrams of pio for the last 18 months. And now he's on a third of that dose. And he had a biopsy repeated as part of a study, and has no steatohepatitis. Still has, and his fibrosis even improved. I think that the box that we are missing is GLP-1s and pio for instead of insulin, and try to avoid insulin at all costs. I agree. Insulin is going to cause hyperglycemia, going to cause weight gain, and is problematic. I mean, overall. And you miss the opportunity of giving them drugs that can help. Now, even SGLT2s cause decrease in steatosis. Probably they'll improve inflammation, but we don't have the data yet. But I would beg primary care doctors, don't jump to insulin. Just use it as your very, very last option. Yeah. Because, and same as sulfonylureas, it's just very cheap, because you're missing using 3 classes of drugs, GLP-1s, SGLT2s, or pio, that can have all the cardiometabolic benefits and improve the liver.
From a management standpoint, when I see something like this, I'm also now thinking beyond standard of care and I'm getting on clinicaltrials.gov in front of, with the patient next to me, because I see destination patients here at Mayo, and I'm finding the closest clinical trial center for which they can be getting access to dual agonist tirzepatide for NASH, a triple agonist that may have antifibrotic benefit, resmetirom, lanifibranor, all those therapies that Dr. Harrison alluded to see what the most accessible potential access to emerging therapies are in local regional areas, particularly now that I have a biopsy, which is within 6 months of any requirement for treatment. And with that,
they also get a lot of education participating in clinical trials from the nurses, from the doctors. It's a liver-centric approach. I think they learn a lot.
That was really an amazing and fabulous discussion. That was my glimpse of what I see with the patient journey from my vantage point, and I really enjoyed the dialogue.
Thank you. Well, that was absolutely fantastic. It's great. It just puts the whole perspective in there. I'm going to invite Kerry on as well because it'd be nice to get her perspective on the patient journey. Kerry, are you on, or can we bring Kerry on again?
I'm here.
There you are. Okay. So Kerry, I mean, you saw this whole broad patient journey, probably from primary care through a hepatologist and this multifaceted aspect. There was aspects within, early evaluation, discussion on therapies, lifestyle changes. You talked about motivation. What do you think? How could we optimize it? How could we change it? What do you think?
I think anytime that there's a question, especially in the early evaluation side of things, go the extra mile and do the testing if you have any doubt, because even things like ultrasounds, things like CTs, they can show you a lot in the scans that may not be picked up through the blood testing and the FIB4, which I definitely recommend as well. My doctor, the FIB4 components were part of the metabolic function panel and the CBC that my doctor initially did that helped me to attain my diagnosis over the long term. But also so were the initial scans. So things, I would say, be proactive and follow your gut. Yeah. If you think that there is something else going on, pursue it.
So I think it goes to Dr. Cusi's comment, right? The gut. And we often say that it just doesn't feel right. There's a high BMI, you're diabetic, the weight's going up, something's fishy with this FibroScan. It's one of those ones where you just repeat the elastography earlier than later to check. Okay.
I've been around my friends in hepatology too long. They taught me all their tricks. So great case, Manal. I mean, we have to give credit. Manal did a great case, very comprehensive, with a lot of twists.
Looking at the primary care perspective lens as well, I wonder, Dr. Cusi, if I have a patient who's got cirrhosis, or let's say advanced fibrosis/cirrhosis, we're worried about sarcopenia, we're looking at weight loss drugs. Do you think, I'm not going to say universally, but almost universally, should they be seeing an endocrinologist as well? I mean, would that be a good enough time for an indication to have endocrinology involved?
I think same as when primary care doctors or endocrinologists, a person with F2 or F3, it's good that they see at least one time a hepatologist, just to not miss a secondary diagnosis. Same with diabetes. I mean, because people with cirrhosis tend to be prone to hypoglycemia, as you said, sarcopenia, and we have some tricks to manage them. And we just wrote a little review. There are many causes for hypoglycemia and cirrhosis. They have some cognitive impairment. The liver is not processing the drug, so they can have, if you give a sulfonylurea, it can accumulate. You don't want to use metformin because it's not metabolized in the liver, but people with diabetes have less reserve to counteract hypoglycemia. I think a one-time visit would be worth it, particularly if they're on insulin, because we have tricks to get them off insulin. And I know primary care doctors are getting very savvy and managing diabetes medications, but these visits are short, and sometimes you can't do everything. Yeah. So different brains on helping the management of a patient can improve the quality of life, I think.
I'm also finding myself really yearning for that strong partnership with an endocrinologist because, here I have a patient who's complaining of profound fatigue. They've been difficult to manage from a diabetic standpoint. They got weakness, and at least I know in patients with chronic liver disease, there is a prevalence of increased adrenal insufficiency sometimes. And I sometimes worry, am I missing conditions like, Cushing's?
Yeah,
Could that be playing a role?
I have picked some Cushing's, that were unsuspected, hypothyroidism. You are very smart thinking about low testosterone. And again, Juan mentioned sleep apnea and undiagnosed heart failure. There's a lot of things that happens in these patients, and drug interactions. If they're on an antidepressive and they interact with another drug, so
it's a great point that it's actually a great point that Dr. Ramji made, in the sense that probably the most common complication of cirrhosis that we don't recognize is malnutrition. And so a lot of these cirrhotic patients are malnourished. They probably have osteopenia or osteoporosis, low in vitamin D, at risk for fractures and things like that. And so, I don't know, the help of an endocrinologist would be very beneficial.
So we have an additional question in the chat group, and it's the question is: we often have incidental findings of fatty liver on abdominal ultrasounds. Can you comment on the correlation between the results of a regular abdominal ultrasound, so not shear wave, I presume, and FibroScan? Who wants to take that?
I think Manal is our expert.
There is no correlation between fat on an ultrasound and fibrosis severity. Okay. In other words, in order to see fat on an ultrasound, you need at least 30% fat. And the fat in and of itself, while it's a biomarker for the risk of chronic liver injury, is not concordant to the severity of chronic injury. The severity of their underlying metabolic stress and age. So if you remember nothing else, and I think Dr. Noordine said this, age over 45 to 50 and the presence of diabetes or 3 or more risk factors of metabolic syndrome, or certainly a first-degree family member, the presence of fat on an ultrasound triggers my 2 questions. Are they drinking? And if not, focus on metabolism, and I risk stratify severity of the risk of fibrosis based on not the fat, but the metabolic stress in the context of the fat.
What we often get here is the patient has a severely fatty liver on ultrasound, which, everybody perks up when you hear the severe fatty liver. It's interesting how people say that. I guess the other conversation piece to this is cardiology. I mean, we got more recent data on GLPs and diabetes and in patients with high BMIs. This cross-pollination is key part. So, Manal or Dr. Cusi and Dr. Juan, when are you getting cardiology involved? Should we be getting cardiology involved a little bit earlier? Should we be getting those echocardiograms to look at LV function? And, is that in the context of drugs in particular, but even otherwise? And last and brief answers, because I think Mike's ready to go for the next section.
My brief comment would be, in the diabetes field, people have done studies, just let's echo everybody, and it's not cost effective and you get a lot of false positives. But you should know that there are many studies now show a higher prevalence of undiagnosed heart failure in people with MASLD, and also in type 2 diabetes. So I think it should be in the back of your mind in any patient like this one who's had a long story of metabolic insults, is complaining of fatigue, a father with coronary disease. He certainly has coronary disease. All people with long-standing diabetes have coronary disease. The question is if they need intervention. So I would definitely be very high on my list to do an echocardiogram or a BMP or consider that this is a problem, particularly because they're missing the opportunity of treatment with weight loss and SGLT2 inhibitors and all the others. So definitely it's an important aspect of care.
Yeah, and that is their greatest risk factor, right? Is heart disease.
The cardiovascular morbidity. Okay,
Yeah.
Perfect. All right. Well, thank you very much to the panel. Thank you very much, Manal, for presenting, and for Kerry for being here and giving us the patient perspective. Hope you have a wonderful night.